Hi guys, today I'll be talking on investigations and treatment part of the infectious mononucleosis. In my previous class, I had talked about the pathogenesis, etiology and the clinical features of this disease. So today we'll be talking on investigations and treatment. So the laboratory findings, there are three classic criteria to confirm or to say this is infectious mononucleosis. Number 1, lymphocytosis. Number 2, to see the peripheral smear. So here at least 10% atypical lymphocytes should be present. Then serological test should be positive for Epstein-Barr virus. So these are the classic three criteria in the lab. So let us start with the complete blood count. 80 to 90% cases shows lymphocytosis which lasts for 2 to 6 weeks. Out of this, 20 to 40% are atypical lymphocytes, downy types of cells are seen. And 40 to 70% cases, there is leukocytosis with the WBC count 10,000 to 20,000 per cubic millimeter. Mild thrombocytopenia is seen in more than 50% of cases and ESR is also elevated. This is a peripheral smear showing atypical lymphocytes in case of infectious mononucleosis. Number 2, heterophily antibody test. In this, there are two tests, monospot test and Paul Bonnell test. Paul Bonnell is an older test, whereas monospot test is a newer test. This latex agglutination test, and here the horse RBCs agglutinate in presence of heterophily IgM antibodies. Whereas Paul Bonnell test, sheep RBCs agglutinate in presence of heterophily IgM antibody. This Paul Bonnell test is less used these days because monospot test is more rapid and more convenient test. Number 3, Epstein-Barr virus specific serology can be done. In this, antiviral capsid antigen is seen. So VCA IgM positive indicates acute infection. VCA IgG indicates past or current infection. Another test is anti-early antigen indicated as EA. This is positive in acute infection. Another is anti-EBNA, that is Epstein-Barr nuclear antigen. Positive, if this is positive, it indicates past infection. Number 4 test, liver function test is done. It is noticed 80 to 100% cases, the liver enzymes are elevated, but bilirubin level is normal. And this dysfunction of the liver function persists for 3 months. 95% cases, LDH is elevated. And PCR for Epstein-Barr virus DNA can also be done if the facilities are available. Let us look at the time course of antibody production, how long it is staying, when it is peaked, and then when these antibodies are waning off. So EA, at symptom onset it is raised, peak is 3 to 4 weeks, quickly declines 3 to 4 months, and low levels may be detected for years. VCA IgM antibody, at the symptom onset it starts rising, peaks at 2 to 3 weeks, then declines by 3 to 6 months. Whereas VCA IgG antibody, it comes later in the acute phase, peaks at 2 to 3 months, then drops but persists for life. So many times till life this is persisting. EBNA during the convalescence phase, and then it remain positive throughout life. Coming to treatment, it is a self-limiting illness. Specific therapy is not required, but certain conditions are there where acyclovir IVIG can be used. So immunocompromised patients, acyclovir can be used at the dose of 10 mg per kg per dose, intravenous 8 hourly for 7 to 10 days. IVIG, that is intravenous IV immunoglobulin, at the dose of 400 mg per kg per day, intravenous for 2 to 5 days can be used if there is immune thrombocytopenia or if the platelet is going very low, then this can be used. Short course of corticosteroids are indicated where 1 mg per kg per day, maximum 60 mg per day prednisolone can be used for 7 days and then tapered over another 7 days. So these are indicated in conditions where there is marked tonsillar inflammation with impending airway obstruction. If there is a massive splenomegaly, if there is myocarditis, hemolytic anemia, hemophagocytic syndrome, or seizure and meningitis. So all these are actually complications of infectious mononucleosis. So in these conditions, use of steroid is indicated, and surgical help is required whenever there is a splenic rupture. And then spontaneous splenic rupture is so much common in infectious mononucleosis. Activity: if there is extreme fatigue, then activities should be restricted for 1 to 2 weeks, giving bed rest. The malaise can persist for 2 to 3 months, and then usually no contact sports is recommended, or any heavy lifting is also not recommended for 2 to 3 weeks because there is high chance of rupture of the spleen. Now come to complications. Life-threatening complications are upper AV obstruction, CNS symptoms, splenic rupture, septic shock, and bacterial superinfection, and these may occur within initial 2 weeks of the illness. Other complications: respiratory system, upper AV obstruction, pneumonia, pneumonitis. Upper AV obstruction is seen in 0.1 to 1% of the cases, that is due to hypertrophy of the tonsils and other lymph nodes of the Wilder's ring. Hematological complications are seen like hemolytic anemia in 0.5 to 3% cases, usually accelerate congenital spherocytosis and hereditary elliptocytosis. These are genetic conditions, so when there is infectious mononucleosis, these are aggravated. Hemophagocytic syndrome is another hematological complication. ITP may gradually evolve to aplastic anemia, and then DIC may occur, that is disseminated intravascular coagulation. Neurologic complication is seen in less than 1% cases. Aseptic meningitis, acute encephalitis, coma, and meningoencephalopathy can occur. Seizures may also occur. Hypoglossal nerve palsy, Bell's palsy, hearing loss, brachial plexus neuropathy, and multiple cranial nerve palsies can also occur. Other neurological complications are Guillain-Barré syndrome, autonomic neuropathy, gastrointestinal dysfunction, acute cerebellar ataxia, transverse myelitis, and Alice in Wonderland syndrome, that is metamorphopsia, that is disorientation with the spatial configurations. Hepatitis may occur in more than 90% children, where LFT is more than 2 to 3 times raised than the normal upper limit, and usually common in 2nd to 3rd week of the illness. 45% cases may have elevated bilirubin, that is a complication, because normally jaundice does not occur in infectious mononucleosis. If it occurs also, percentage is only 5%. So very highly elevated 45% cases is seen. If it is seen, that is a complication. Splenic rupture is seen in 0.1 to 0.2% cases. Autoimmune complications can occur. Autoimmune disease and Ray's syndrome is common. Acute disseminated encephalomyelitis can occur. Infectious mononucleosis, actually it stimulates the production of antibodies like anti-1 antibodies, cold hemolysins, anti-nuclear antibodies, rheumatoid factors, cryoglobulins, and circulating immune complexes. So antibodies precipitate autoimmune syndromes. Cardiac and pulmonary complications are not very common. It is rare. So if it occurs, there might be chronic interstitial pneumonitis, myocarditis, pericarditis, interstitial nephritis, pancreatitis, genital ulcers. These are some other rare complications. The prognosis If the patient is immunocompetent, there is full recovery in several months. Hematologic and hepatic complications resolve within 2 to 3 months. Neurologic complications, in case of children, it resolves quickly, but in adults, neurological deficits may occur. All individuals develop latent infection. Prevention is by isolation. Actually, isolation is not required and it is not recommended because this is not spread through the contacts or touching with each other. But you have to avoid the contact with saliva. Do not kiss the children on mouth or do not give the pre-chewed food to the infants. Maintain clean conditions like daycare and avoid sharing of toys because toys you may contaminate with the saliva. And there is no vaccine for infectious mononucleosis. Development is in progress, but yet till date, there is no vaccine for infectious mononucleosis. Thank you. Next class, I'll come up with another infectious disease.